Okay, thank you very much indeed. I think we need to move on. There are one or two other questions which we'll take in the panel discussion. So we move on now to Henning Bliddal's presentation on older people with obesity and osteoarthritis. And this is entirely and very particularly appropriate at the present time because, of course, certainly in the UK and I'm sure elsewhere, what we're going to see is delays to the availability of knee replacements and hip replacements. So there are going to be an awful lot of people who are going to be waiting a very long time. And of course, osteoarthritis is common among our older populations and often overlaps with diabetes. So Henning, please. Thank you.
Thank you so much, Tony. And thank you for being able to participate in this very interesting lecture, actually, both from Carel and Mike. Wonderful presentations, thank you. I'll try to come in. Where does this work? Yeah. I tried to go through with you some of the interesting facts that we've learned over the years working with elderly obese people at the same time having osteoarthritis of the knee. And I'll just, with this disclosure, tell you that much of the study I go through has been sponsored in part by the Cambridge Weight Plan. This is the session outline, and first a bit about osteoarthritis. Some of you will be very familiar with it, some other, but bear with me, I'll just go through a few points of this, then talk of the connection between obesity and osteoarthritis, and in the end go through our results with the weight loss trials in this group. We all know that age is paralleled by troubles from here and there, and joint troubles indeed will increase with age, as you can see. And the red bars in this slide will show you the dependency on other people that increases dramatically when you get well, over 85 years, as you can see. But more or less half of us in the elderly group will have joint troubles. When you ask people which joints this is about, it's the knee. The knee is a very social instrument, and beware that the knee will take you around in the world. In this case, you can see that much of the trouble people complain about will be the knees. So it's an important instrument to all of us at that age. Osteoarthritis symptoms are pain and stiffness and loss of function. And this will not depend totally, but be somewhat correlated to the degree of osteoarthritis as seen on the X-rays. And we grade the osteoarthritis from the X-ray to 1, 2, and 3, and grade 4 will be what we call joint death, more or less, because this is end-stage osteoarthritis where you have very severe changes. And on the left, on this panel, you can see a grade 4 change in the knee with bow-legged appearance and the cartilage more or less worn down in the medial compartment of both knees. It's quite common to have this, and 10% of the population above 55 years old have a wish for treatment of knee trouble. Most of the studies you'll see dealing with osteoarthritis go into the grade 2 and 3 participants, but in our case, I'll show you some data with all grades being able to participate. Now, what happens with osteoarthritis? You can get a quick look on this. This is taken from an overview in the Lancet a couple of years ago, and you'll have the reference with the next slide. But you can see that the healthy joint is depending on cartilage, sound layer of cartilage, above a good and well-functioning bone near to the cartilage, and a very thin synovial tissue feeding all the joints. What happens with osteoarthritis is that all this will change. As you can see, it's not only the cartilage being worn down, but also changes appear in the bone near to the joint, in the synovial tissue, and even not on this slide, with all other soft tissues around the joint. And if an interesting point with the symptoms of osteoarthritis is that there are no nerves or at that blood vessels in the cartilage. So something else must be causing the damage. And we know now that much of the symptoms you have with osteoarthritis stem from the inflammation accompanying this process. So it's a biochemically active environment, and it's all attacking the cartilage in the end. Here you see an MRI scan of a knee seen from the lateral aspect. You can see on this slide the kneecap. There's fluid, there's fluid in the bursa above the knee. Here you have the femoral bone, and in front of all this you have the fat mass of the knee called the Hoffa's body. If you put contrast into this, it has been given the gadolinium contrast, and repeat the MRI scan, you can see that the synovial lining of the bursa is enhancing, which is in fact a sign of inflammation, and also the Hoffa body is enhancing. So much of this is inflammation, and 85% it seems of the correlation is between the inflammation in the Hoffa body and the degree of pain reported by the patient. Now, obesity is very closely linked to osteoarthritis. And this is a British study, epidemiological study, trying to figure out what is the risk of having end-stage osteoarthritis when seen in a connection with BMI. And both this and data from the States show us that the risk of acquiring knee osteoarthritis increases dramatically if you go into the overweight and obese BMIs. And you can see here that it's almost exponential towards the end. This is quite parallel to the experiences we have from the outpatients clinics at the hospitals. The knee OA increases dramatically with obesity. An interesting point I'll just draw your attention to is that we have data pointing at a risk for OA also in non-weight bearing joints. That is, the hand OA will increase also with obesity. So some other factors than the mere weight will have to be there. And we know that the obese tissue will be quite active, and you have a number of factors being produced in the obese tissue, so like fat hormones, as we call them, and they all attack joints, it seems. There's no proof of this, but pretty much circumstantial evidence from a lot of studies, as you can see. Now, what happens if you lose weight having OA? The interesting point here is that people with bad knees cannot just be asked to increase their daily activities, not much, at least not as much as we would like to, and in any case, not enough to lose weight just by increasing activity. So these people are actually having a lot of comorbidities with their obesity, and one of them will be knee OA in many cases. So here's the Lancet publication again, and it summarizes what you can do yourself, and the most important thing if you are obese will be a weight loss. This is on top of the list. Of course, you can increase the exercise and that'll be very good for you, but it seems that a weight loss is definitely the primary thing if you have a combination of osteoarthritis and obesity. In our first study, as you can see here, we had participants going in groups led by a dietitian, and they were given 8 weeks of low energy diet or very low energy diet and lost a lot of weight during this phase. Later on, food was reintroduced, and as we heard from other studies, we tried to teach people healthy food, but even so, being hyper-energetic, there was no significant weight loss during the follow-up phase. So it's a more stabilizing idea to have people attending these groups during this phase. The typical participant in this study was a 67-year-old lady with a BMI of about 35. But we had all kinds of participants, but of course it's mostly elderly people with knee osteoarthritis being part of this study. The weight loss resulted in a quite dramatic improvement in osteoarthritis symptoms. We have in osteoarthritis the internationally recognized OMERACT-OASI response, and about 30% of the improvement could be related to the weight loss of 10%. So 2 out of 3 gained significant response to this program. This response was reached whatever grade of the radiographs. You can see that even grade 4 people were having a good chance of having symptomatic relief. So this led us to the notion that bad knees are no excuse for not losing weight. We carried on after the first 16 weeks with a stabilizing 1 year, and divided by randomization people into a continuous diet group, a control group, and a knee exercise group. And of course, this again, these people couldn't exercise to any major extent, but it seemed that just being in the exercise group led to some regain of the weight loss. Sorry for this group. But the diet-only group fared pretty well. And as you can see from the dropouts on the right side of the panel, the diet group is the most happy group with excellent compliance to the program. Dropouts were seen with controls and exercise more often. What happened to the body composition during this phase? And this is the title of the talk, I guess. You can see that the vitamin D increases dramatically. Part of these participants are on very very unhealthy diets, and this is quite common with obese people, that their daily diet is unstable and irregular and not very healthy, sorry to say. In our hands, you could reach this weight loss with a very little loss of lean body mass. As you can see, only a few percentage lost. And the major weight loss was due to loss of fat mass. If we concentrate on the vitamin D, you can see that at the onset, at baseline, about half of the patient were vitamin D deficient, with a vitamin D level of below 50 at baseline. And this changed quite a lot during the 16-week weight loss program, that we saw an increase in vitamin D, and the number being below the reference range decreased quite a lot. During the following year, as you can see at the lower panel, the diet group decreased, or the number of deficient vitamin D participants decreased even further, and this was significant in comparison with the other groups in the randomization. So in the end, the diet-only group only had 8% vitamin D deficient. If we look at what this costs in grams of bone mineral, you can see again that it's not any trouble really with the initial program of the 16 weeks. During the follow-up phase the following year, you can see that we lost in the participants some bone mineral, even in the diet-only group, but again, this was less pronounced than seen in the other two groups with exercise or control. We carried on with these people for years and actually did a 3-year further study, dividing people again into 2 different programs, all led by the dietitian. One of them had 18 visits distributed over the years with the dietitian, and were allowed 1 meal replacement per day during this period. The other group, as you can see, yo-yoed a bit with their weight, and they were given the same amount of diet replacements, the same amount of visits to the dietitian, but this was concentrated for periods of 5 weeks every 4 months. And you can see that most of these people gained some weight during the other period, and during the intensive dietary period, they lost it again. And in the end, there was no significant difference between the baseline weight for this program and the end weight in the, should we say, the group having the diet replaced for 5 weeks every 4 months. They were exactly at the same weight, while the continuous one with 1 meal a day replaced gained a bit of weight, but it wasn't that much. And everyone was happy with the program, and we lost, as you can see, over these years, some 30% of the participants. Oh, sorry, I've just another point. These people, at least half of them, have very bad knees. And during a phase, as you can see, up to 4 years, we didn't see much surgery, knee replacement surgery for this these very bad knees. So I think this is part of the outcome being participant in programs like this, that you reduce the number of knee replacements. As another point to make, I can tell you that having a knee replacement will not lead to a weight loss per se. In fact, people will gain a bit weight after knee replacement on average, and I think that this may be explained by the lack of knee pain, which again leads people to overeating a bit more than they used to. Also, in this material, we did the Q risk, as mentioned by Mike just a moment ago. And as you can see, the chronologic age was 63 at baseline. And sorry for, again, the typical participant ended up being 67 years. But you can see that during the weight loss program, people actually chronologically got older, but by the Q risk, heart age years reduced quite a lot. So they were, with respect to heart age, if you accept the Q risk version of this, you can see that they got quite younger during this program. In conclusion, osteoarthritis of the knee is clearly associated with BMI and age, that is. Weight loss will reduce your risk of knee osteoarthritis, and the weight loss of some 10% will reduce symptoms quite a lot, and this can be obtained whatever the radiographic status of the knee. Finally, weight loss can be obtained with total diet replacement, and during follow-up, in this case up to 4 years, you can stabilize this weight loss. So thank you for attending. Thank you, Tony, again for letting me participate in this.
Thank you very much. Thank you for that splendid summary. Now we have a number of questions from individuals. One asks, does losing weight fast affect the joint positively or negatively? I suppose they're suggesting, is there a short-term effect on the joint, which may then be ameliorated by increased strength of muscles around the joint and so on? What do we know from clinical practice?
Well, I'm sorry to admit that we've had a lot of studies going on these participants, and in the end, they don't become more active at all. We had a small accelerometer placed on their leg and could follow their activity over the 24 hours, and nothing happened. In the end, they were just as inactive as at baseline. So nothing happens to the activity. With respect to whether or not it's good to lose weight fast, it seems that the psychological factor of reaching a good result with this is very important. So people tend to be very happy losing weight fast, and they also adhere to the program better if they can see this fast weight loss. So it doesn't really affect the knee whether or not you lose the weight fast. This is kilo to kilo. You get better, but it's a psychological factor that should be regarded as very important. With the fast losers are more happy, simply. And if I might add a bit, you'll have to know that moving the body will cause a lot of, or will be depending on a muscle contraction over the joint. So if you weigh 100 kilo and must take a step, the muscles around the joint will produce a pressure of at least another 100 kilos on the joint. So in the end, in the joint, you have a pressure of at least twice your body weight. And ordinary walking will give you a pressure in the joint of 3 to 4 times your body weight, which on the other hand means that if you lose, for instance, 10 kilos in the joint, you will have a 40 kilo reduction of the pressure. So this is quite important for the joint, of course, but we haven't been able to prove that the cartilage destruction is changed by weight loss, sorry to say.
Here's another important question from Rimbadas. Does a person who's going to have a knee replacement, should they use this type of diet before surgery or only afterwards?
Well, I would definitely suggest that they use it before surgery because it reduces all kinds of complications with the surgery. We heard from Carel some of the obvious problems being obese, and this is all reduced with weight loss, which also gives you a better outcome of the surgery. So definitely before surgery would be good. And also we have tested this in another study in Denmark, that people, as I showed you, get healthier. So it's a healthier surgical material to be, in the end, operated.
Yeah. Thank you very much. There are 1 or 2 other questions which we'll take in the main panel, but thank you very much, Henning. We'll move on now.